Good afternoon. First, I would say thanks to Dr. Vijayakumar and the 3D Food organization team for giving me this opportunity. That post-lunch session, Dr. Muralidharan made me easy to present. Most of the things he has examined, he has explained. My topic is examining for diabetic foot. Examining for diabetic foot, we all know that the diabetes is associated with more than half of all non-traumatic lower limb amputation. It occurs mostly vascular, neuropathy, everything, mostly pathophysiology is discussed by Muralidharan. So you all know that each foot is made up of 26 bones, 30 joints, 100 muscles. It is an amazing and respectable part. But the most neglected part in our body is the foot, lifelong weight bearing center. So this is the tip of the iceberg we can compare with the diabetic foot. All pathological hidden part can be seen the tip of the iceberg. We are seeing this is the common scene we are seeing now mostly in the diabetic clinic. This patient came with the fever, not for foot ulcer. You see there is anything in there in the fifth toe. There is, see, this patient came with a sepsis. This is a common scenario in our daily practice. So this patient goes for a amputation and wound debridement. So this thing is welcome. Please remove or show. Dr. Murali has explained. So all diabetic clinic, please encourage patients to wear the foot. An examination of diabetic foot, not only examining the foot and also the footwear also. The foot ulcer is a rule of 15. 15% of the diabetic patients have foot ulcer in the lifetime, 15% osteomyelitis and amputation. So the clinical assessment, neuropathy, gait assessment, high stamping gait is there, then sliding foot, sensory neuropathy, then foot scrapping, that is foot drop gait, so many gait type, ulcer without limb, severe neuropathy, and ontologic and calcaneal gait, tendo gait. The clinical assessment of the skin, dryness and turgid veins, nails, loss of hair, so many things we have to examine, like all body examination, redness of the skin, so many things. So neuropathic foot is warm and veins will be prominent on the dorsum of the foot due to the arteriovenous shunts resulting in the from autonomic neuropathy. Whereas neuropathy, painful, painless leg, the classical diabetic peripheral neuropathy, bilateral symmetrical, the sensory component predominates, the paralysis of the Bobjuti examination, there is blunting of pain and temperature sense. Sensory disturbances generally appears early in the distal portion of the lower extremities, eventually progressing to a stalk and gloving distribution. Involvement of the large sensory and motor fibers impairs light and touch proprioception and causes weakness in the intrinsic muscles of the feet with alteration of the pressure points. Neuropathy can be assessed by the clinical examination and conduction studies. Neuropathic ulcers, intrinsic factor, limited joint mobility, bony prominences, foot deformities, plantar callus, so many neuroarthropathy, scar tissue and all. The intrinsic factor is the footwear injury, thermal injury, object inside the shoes. Intrinsic factors, claw toes, plantar callus, so many fissures and all. So routine, the examination will be explained following video. I am going to discuss in the view. This is arithmetic I want to discuss. You can see the alter pressure points. Well, a simple test we can see, we can do each and every patient in our clinic. So ischemic limb feet is cold with absent pulses, blanching on elevation of the delayed venous filling. Skin appears shiny. It's more reliable parameters of the prevailing vascularity. Sophisticated technique like skin blood flow calculation from the xenon, 133 clearance, transcutaneous oximetry, cutaneous blood flow is more this, so and so. So infection, if the patient is suspected more than osteomyelitis is suspected more than bony of the over the bony prominence, it should be differentiate the osteopathy and the osteomyelitis. Whereas in osteopathy is a peppermint stick in the X-ray, the multifocal bilateral normal leukocyte And yes, sir, the distinction between osteomyelitis and osteopathy is made on clinical grounds. Kindly watch a video. This is the video I made. Oh, sorry. To save the time, uh, kindly play. Play. This is a 3 minutes examination. So, this is a good physical interaction. General. Volume ಹೆಂಗೆ ಇದೆ? So each patient has to, as the time consuming, each and every patient has to be examined like general medicine, CVS, RS, CNS. This kind of uh, uh, patient history is very, very important for the dealing with the. It is I'm discussing very fast. Any amputation, any previous history of a smoker, hypertension, family history.
Has to be examined regularly because examining see the skin health.
Skin is very important.
Any hair growth,
Any dry skin,
skin, any roughness, any dryness of the skin. Temperature should be
temperature.
low.
Callus, fissures, each interdigital has to be examined. And posterior, any pain in the calf muscle, interdigital nails has to be examined. Interdigital. Dorsalis pedis pulse palpation. And posterior tibialis artery. Popliteal pulse. Femoral pulse. Capillary refilling is very important. The toes, just press and use the refilling. Cotton wool touch sensation.
Yes.
Pin prick
Yes.
touch.
Yes. Yes. Yes.
Ask the patient to close the eyes
Okay.
and say,
Some protective situation under diabetics are tested a simple SIMS
10
monofilament test.
10 gram monofilament test. This is the test, you can see, very easy. Just you make it a plug, buckle the, touch the foot, give a gentle pressure, just buckle. Monofilament test.
On the vibration
128, it's a tuning fork test.
vibrations can be seen by just keeping
The bony prominences.
ask the patient to close the
Vibration test at bony prominences. These things you can finish within 3 minutes. Next, vascular posterior tibialis pocket Doppler. It will be
is the posterior tibialis artery with the pocket Doppler.
dorsalis pedis artery.
Important test
Ankle
the ankle
brachial index.
vibration sense
By,
meter is going to keep
by the symmetry. Ipswich touch test. This is a simple test by using the touching the first, third, and fifth toe by asking closing the eyes of the patient. Proprioception test, whether the patient can feel the movement of the toes.
Yeah. Oh, the
Harris mat,
test.
simple.
Just
Walk. The clinic. Patient footwear, examining the footwear. That's why you have very important. Inside the footwear, so many things, pebbles, pinpricks. The examining by mirror, self-examination. He has to be educated, each and every diabetic patient, to prevent the foot complaint. These are some of the things we are going to discuss. Fissure, callus, and forward it. Oh, others. Arnakia with these all things. So with this, I finish a small discussion. Thank you very much for giving this opportunity.